This is Dr. Hady Lichaa, interventional cardiovascular specialist, going over the filtered blood autotransfusion technique, which is highly usable in situations where we pull large amounts of blood from the patient and would like to give it back in a filtered fashion without a dedicated filter. This technique was invented by my great friend, Dr. Matt Wiesenen. He's a very innovative structural interventional cardiologist at Park Ridge Medical Center in Chattanooga, Tennessee. This is a bench representation of the circuit, which is centered by a hemanetics filter, which is a filter used in blood transfusion, widely available in most hospitals. And this is a picture of the package of the filter itself. We have no conflict of interest related to any company making any transfusion filter or any other devices described in this case. So this is a man-made blood loss autotransfusion system made out of two 11 French sheaths and the hemanetics transfusion filter. The three components, obviously there's a donor sheath, as you see right here. This is where the dirty blood, basically the blood that was removed from the patient, gets transferred into the filter. The hemanetics filter obviously clears out the clots and the aggregates. Then this is the sheath that receives the filter, and both sheaths are obviously connected to large syringes, 30 to 60 ml syringes, so that this process is relatively fast. So this is the hemanetics filter itself. There's an inflow cannula from here. This is supposed to spike into the blood transfusion bag on this side, and the collection chamber, the filter itself, and the outflow cannula over here, which is supposed to be compatible with the spike chamber and the tubing that is ultimately connected to the IV of the patient. But we're obviously using this filter to filter the blood outside the body before we give it to the patient. So as you see here, the 11 French sheath is not really compatible with the inflow cannula, the spike itself. If you try to place the sheath over it, it is actually not compatible, as you see right here. So in order to do that, we would have to cut the sheath with any scissors. The sheath is cut in half, basically. And then the sheath dilator is taken, and the remaining portion of the sheath is slid back onto the sheath itself. This is gonna allow us to deliver the actual sheath. So the dilator is pushed really snug into the spike cannula, and then the sheath itself is going to be slid over the dilator, and at that transition here, this is where it gets really snug. So you're going to rotate over the dilator to try to get this 11 French sheath to stay there. So it takes just a little bit of push over the dilator, and that's it. So that's the inflow cannula itself. And then the outflow, the good thing about the 11 French sheath is that it fits the outflow cannula very, very well. So exactly the size, and it fits, and it's snug. So two 11 French sheath, and then this is the flow direction. Let's describe a case where we used this technique. This was a massive tricuspid valve vegetation case in a non-surgical patient who required aspiration of this tricuspid valve vegetation with the AlphaVac device made by AngioDynamics. Again, no conflict of interest. So the large vegetation was very successfully aspirated with this device. The downside of the AlphaVac is the blood loss, and we use that technique to compensate for that. So as you see here, the lost blood is actually being filtered through the 11 French sheath donor into the hemanetics filter back to that syringe. And then as you see, the blood here is going to be given to the patient through the central access that was used for the procedure. This can be used in any other surgery or procedure where large blood loss is expected.